how can we use things that we now call neuromodulation to change or train spinal circuits in this case. And this is great because we have a group like ART that is going to help develop new circuits and so forth. So the idea of merging these techniques makes a lot of sense. And at the Spinal Cord Injury 2020 conference, Mike Boninger and Laura Miller, that used to work for ART, we were sitting and said, why don't we start doing some collaborative work, which has now led to this workshop to try to drive some of this collaborative work. But also, we have already funded one pilot grant awardee between the two centers that is working on merging the neuromodulation approaches and the regenerative rehabilitation approach. So it's a very exciting time. It's a burgeoning area, and we hope that ideas will be stimulated, new collaboration stimulated, and we will advance the field. So Linda Noble from ART would like to say a few words too about the conference.
Yes, I'm really excited to be here today. I'm here in the University of Texas at Austin, and I'm representing AR3T today. And many of you probably already know this, but we canceled this year's International Symposium on Regenerative Rehabilitation due to the pandemic, which was to be held in Austin this very week. So this workshop today was an important part of that symposium. And I just want to express our gratitude to NMR4 for their willingness to maintain the integrity of this workshop through this virtual platform today. So I'm really looking forward to these presentations and the discussions that will ensue. Thank you, Rick.
You're welcome. And as people review the schedule for today, we are going to have several talks that will be primarily focused on neuromodulation, but also talks that are where the approaches are merged, or how could one benefit from the other. In our concluding session at the end, we have a couple of attendees that are going to present some ideas that might spark some discussion. And we'd also like to conclude with a lot of discussion about the ability to merge these techniques or use them in a synergistic way to advance the field and maybe establish some future collaborations. So without any further ado, why don't we go to our first speaker, who is present here now. And our first speaker is Franklin West from the University of Georgia in Athens, Georgia. And the title of his talk will be How Regenerative Rehabilitation Can Benefit from Neuromodulation. And I think he's changed the title a little bit, but that's okay. Take it away, Franklin.
Sorry about that. Got stuck with mute there. So yep, just changed it a little bit. And so title of the talk is Neural Stem Cells and Structured Treadmill Walking, Rehabilitation and Motor Cortex Traumatic Brain Injury. All right. So as many of you probably already know, traumatic brain injury has become a silent epidemic. Almost 3 million Americans every year go to the emergency department with a traumatic brain injury, and about a third of those are children. And so children often have traumatic brain injuries due to falls. They fall out of cribs, high chairs, down stairs, and this ultimately leads to a direct impact injury or a focal injury. The other most common cause of traumatic brain injuries children is acceleration and deacceleration injuries. And so this can happen when a car has an accident and the brain is thrusted forward, and ultimately could lead to shearing between gray and white matter, microbleeds, and other types of injury. And so over 37,000 children suffer severe traumatic brain injury every year. And the reason our group focuses on severe traumatic brain injury is because it accounts for about 90% of the cost of traumatic brain injury. So it's a significant component of that. And so about 20% of children experience severe traumatic brain injury die, and about half have unfavorable outcomes long-term. And so this includes things like abnormal brain development, abnormal brain function, cognitive problems, so short-term memory, long-term memory, processing of information, integrating complex information, behavior problems such as fear, anxiety, PTSD-like symptoms, and what our group is focusing on as part of this project, motor function. And so many of these individuals have long-term fine motor skill problems, gross motor skill problems, and they're ultimately unable to feed themselves, dress themselves, and need extensive motor support for their motor deficits. And so my laboratory is a stem cell laboratory, and we're really excited about induced pluripotent stem cells. And this is an exciting technology because you can actually take cells from the patient, introduce different reprogramming factors, so transcription factors like OCT4 and SOX2, and you can turn these adult stem cells or adult cells into induced pluripotent stem cells. So pluripotent meaning that they can turn into any cell type in the body. And these cells can be differentiated into neural stem cells and transplanted back into the patient. And this gets around the issue of rejection. And so the idea here is that they perform cell replacement, so they turn into neurons and other important cell types. But what we've discovered over the years is that neural stem cells don't only just replace the lost and damaged cells, they're actually immunomodulatory, so they can push cells from macrophages and microglia from an M1 inflammatory state to an M2 state. They produce angiogenic factors like VEGF that will support vasculature after traumatic brain injury or promote new vascular formation. Also neurogenesis, so these cells produce neurogenic factors that we've shown that promote endogenous neurogenesis in the subventricular zone and lead to increased migration and engraftment of endogenous cells. So they have lots of possibilities. And so here are some iPS-derived neurostem cells from our group. You can see that they express the neurostem cell markers SOX1 and nestin. They can be differentiated for 30 days or so and form beta-3 tubulin MAP2 positive neurons, GFAP positive astrocytes, and O4 positive oligodendrocytes. And so that is actually the original proposal that we recently got funded from the National Institutes of Health. But we've always been really excited about working with Jared Call, who is my collaborator on this project. And we were able to put together an R3T grant and submit it and add a component of exercise because we've been really excited about the potential here. It's very practical. It also has a history behind it of significant improvement in recovery. So TBI patients have shown decreased depression, anxiety, improved quality of life. It's relatively low risk and well accepted by patients. In many cases, it's just simply walking and you can adjust it yourself. And so there's very little pushback relative to some other types of treatments. There is a need for additional controlled studies though, and we think that's kind of where our group is adding to this, to the literature. And the other piece that we're adding to through the study that we recently got funded through the AR3T grant is being able to focus on pediatric. And so most of these studies focus on adults when they include exercise, and ours is going to focus on pediatric. And so recently there was a study in rodent models where they showed that exercise led to decreased lesion volume, axonal degeneration, improved, reduced anxiety and plus T maze assessments, improved neurocognition in Barnes maze testing. And we're really excited about this publication is that there was an increase in endogenous neural stem cell proliferation. And so what we wanted to do is combine this together because we know that exercise improves endorphins, increases factors like BDNF and GDNF that may promote our transplant in neural stem cells and their engraftment. And so we think that this could be a synergistic approach. And so the other piece to our story is that we're actually interested in large animal models of traumatic brain injury. And the reason for that is, as many of you know, there's been hundreds of clinical trials for traumatic brain injury, And there's been different conferences and groups supported by the National Institutes of Health and Department of Defense, getting together experts, trying to evaluate why we still have no FDA-approved treatments, despite the fact that we have hundreds of clinical trials. And so our group is in the Animal Dairy Science Department at the University of Georgia. And so we have access to a number of different species from sheep, bovine, and others. And so we were considering what are some of the key characteristics that are important for assessing cell transplantation. And so some of the things that we evaluated or considered were the size of the brain. So the human brain and the mouse brain, and the mouse and the rodent system is obviously the most commonly used system to study traumatic brain injury therapies. So we considered the size of the brain as an important variable. And so we know that human brains are 650 times larger than the mouse brain. And this is important because it affects the number of cells that are going to be transplanted, number of transplantation sites, on whether we need extracellular matrices supports, what kind of vascular support are they going to need. Also, the other factors that we've considered were the basic architecture. So the human brain is gyrocephalic, meaning it has gyri and sulci, as you can see here. The rodent brain is a smooth brain, and so it's lissocephalic. And this has a direct effect on connectivity. And one of the things that our group is really excited about is looking at brain networks. And as part of this study, we are focusing on motor networks in the brain. And so looking at connectivity is critically important, and there's definitely different connectivity and relationships in connectivity based on your standard architecture. In addition to that, we considered white matter as an important variable for traumatic brain injury as well, because the human brain is more than 60% white matter. The rodent brain is less than 15% white matter. And we know that traumatic brain injury affects white matter differently than gray matter. So it's an important component to consider. And then there's also differences between growth and development. So ultimately what our group has done is we've developed a traumatic brain injury model in the pig, because instead of being 650 times smaller, it's about 7.5 times smaller than the human brain. It's gyrocephalic, and it has more than 60% white matter and has comparable growth and development. And considering that we're looking at a pediatric model, that's a key component. And so we've developed this model over the last few years. And we've shown that traumatic brain injury leads to significant lesioning, swelling, atrophy of tissue. We see glial scarring, activation of microglia. And so it's fairly consistent to what we see in human patients. The other piece that we've been working really hard on is developing functional MRI in the pediatric pig model. And so this is what I'm going to show you here is a normal brain activation, and this is going to be in the motor center. And so you can see activation here. After TBI, we see a loss of activation. Here in the normal animal, you can see activation. And after TBI, it actually is activated on the contralateral side. And then here in the normal brain and in the TBI brain, you can see that there's hyperactivation. And so we're able to look at different changes in the brain. So deactivation, changes in activation, different compensation mechanisms. And so here's some data from our tactile stimulus task-based fMRI. And this is a novel approach in pigs. And so we use two different types of machine learning approaches to analyze our sensory motor network outputs. And so we used ICA analysis, which is represented here by the Pearson spatial correlation coefficient. And we also use sparse dictionary learning, which is represented by the mean ratio. But the bottom line is, despite us having two different analysis approaches, we see that overall the sensory motor network, there's a significant decrease after injury. And then when we separate it out into different nodes in the sensory motor network, so there's a decrease in the primary motor network and in the somatosensory associative network. And so we've developed a number of fMRI techniques. We can look at the visual network. We also look at resting state MRI. And so, as I said, we're trying to really combine this together, really focus on the motor network. And so one of the other components of this story is that we're really excited about looking at changes in motor function. So we look at gait analysis, and we use a MAT-based system with thousands of sensors. And so what you're going to see here is a pig that's going to transverse the mat. Ultimately, you're going to see footfalls from right to left, and you're going to see the activations of thousands of sensors. And this is a really nice system because when you have a traumatic brain injury and motor function problems, a lot of times you may take shorter strides because you need to increase your stability. You will change your cadence, your velocity, or if you have for example, an injury on the right side, the left side of your body is going to have limb weakness. And so you shift your weight to the right side. And so we're able to pick up a lot of really fine adjustments in motor function. And so I'm going to go ahead and hit play, and the pig is going to walk down the mat. You can see all the sensors are being activated. And so this gives us significant power, in fact, to evaluate over 39 different parameters for each limb to determine significant changes in motor function. And so we've validated this system and shown that with increased injury, so we have 2 meters per second, 6 millimeters penetration depths. And so this is our injury models. And so we've evaluated 4 different severities, and we're able to show that we see differences in things like stance time. So increased stance time is an indicator of basically a need to stabilize in your gait. So you want your feet on the ground more so you have an increase in stance time. And so we do see that, for example, in our more severe injuries, that after TBI, we see increased stance time at 1 day, 3 days, and 7 days. And so we've validated this system as well in our pig. And so we're also, as part of this proposal, we're going to be evaluating changes in muscle torque strength. And so this is with Jared Call's group, and what he can do is he can stabilize the knee, activate the muscles, and he can look at changes in torque. And so this limb will actually flex, and he can see how much power it generates, and he's able to measure that. And so what we've done with a collaborator, Luke Brewster at Emory, is we looked at another condition, critical limb ischemia, where they actually cauterize a vessel or constrict a vessel in the limb, which leads to loss of blood flow. And unlike TBI, where you have TBI and there's an acute drop in muscle strength, it actually leads to a slow progressive drop in muscle strength. And so here they've used this paradigm to measure loss in muscle torque strength here. So here's pre, and you can see that it's decreasing over a 4-week period. Ultimately, though, what they've been able to show using walking or motor function exercises over a 4-week period, that they can decrease this loss in torque strength. And so as I said, we just recently got this grant. So we've just started, so we don't have any data today to present to you because it's a double-blinded study as well. But as part of the R21 grant, we're addressing whether INSE transplants transplanted into damaged primary motor cortex will undergo region-specific differentiation, leading to neural network and motor function recovery in our pig model. And as part of that, we're evaluating histologically our neural stem cells to see if they're differentiating in the gray matter, white matter. Are they forming cortical layers in the gray matter as well? We're also, of course, looking at structural changes, microbleeds, changes in perfusion of the brain, connectivity in the brain as well, and then ultimately correlating that with improvements in motor function. As part of our AR3T supplement, where we've been able to add the exercise component to the study, we want to determine whether exercise will improve INSE engraftment and greater functional network connectivity relative to INSE or rehabilitation alone. So we've added 2 additional treatment groups. So we've added structured treadmill walking rehabilitation 5 times a week. And so at stage 1, so the first 1 to 4 weeks, they're walking at 2 miles per hour for 30 minutes. Stage 2, we're actually ramping it up, and we're doing 20 minutes of walking at 3 miles per hour. And stage 3, we're ultimately increasing it to 4 miles per hour. And then we're also looking at the combination of the 2. And so, as I said, at this point, we've started a number of the traumatic brain injury surgeries. We've also started, we've got our treadmills in place. And so the study has begun, and hopefully next year when I come back and talk, I'll be able to show you some more of the outputs that we have from this study. Any questions?
Please put your hand up if you have questions. I guess I have one, Dr. West.
Yes, sir.
Do you, I noticed that part of the protocol is, you can do electrical stimulation and so forth. Do you measure muscle activity during walking, or are you only measuring the forces?
Right. We don't have the capability to measure electrical activity during walking at this point. So at this point, we're focusing on the forces.
Any other questions?
Yes. Yeah, it was a great talk. I tend to think of mild to moderate traumatic brain injury as being a disconnection syndrome. So I think it's interesting, fascinating to see the results of your MRI analysis. But from a mechanistic standpoint, in terms of stem cells, are you thinking of them here mainly on their sort of modulatory effect, on or trophic effect on white matter? I mean, it seems not only less likely that you'll get long range connections and integration of the stem cells, but also that it's maybe not the mechanism that you'd expect to affect restoration in this model.
Right. That's a really great question. Because the field is transition to thinking more about the trophic effect, right? In many ways, because we do know that they have all of these secondary activities and that there is a low engraftment rate. And so typically studies that are able to do a stereology or something along those lines, and even in our pig models, the engraftment rate has been less than 10%. And so a lot of the focus has been on the trophic effect. However, there's been recent publications in traumatic brain, well, actually it's a stroke model, where they've showed that with a loss of engraftment, they saw a significant decrease in functional network activity at a resting state in rodent systems. So it definitely does appear that the engraftment and long-term survivability of the cells is a component of it. So I wouldn't say it's one or the other. It's really going to be a synergistic activity. And one of the things that we are trying to tease out, we're starting to submit some proposals where we can actually we can add lethal genes and knock out the cells after we've transplanted them to see if it is more of a trophic effect. So, but that's a great question.
Thank you. Great, thank you.
Linda?
I just have just a very basic question, and that is, when do you transplant the cells? How far out do you wait before you transplant? And then just from a logistical point of view, how long can you keep these pigs to study the longer term consequences?
Right. Great question. So we transplant 5 days later. And the reason for that is acutely the environment is so cytotoxic. And considering that we are trying to look at engraftment, we transplant at a later time point. Some groups, when they're focusing on the trophic effect, they'll transplant them more acutely, trying to modulate the immune system before it gets a chance to ramp up. And so that's why we transplant 5 days later. This study is a 12-week study, so 3 months is how long we're going to keep the animals. But we would like to do some more long-term studies, since we're able to look at changes in functional network and reorganization and plasticity. So we'd love to be able to do it, take them out for a year, 2 years or longer. But right now we're at 3 months.
Jessica Bath?
Hi, yeah, I just wanted to say I really enjoyed the talk, and so I'm very new to this, but we're looking at UCSF doing some expanding on work that's been done in non-human primate models for stem cell grafting for SCI. And we were trying to look at exercise too as like an adjunct. And one of the issues we're coming up with is just timing of the intervention and its application and when you're transplant, so that you're not hindering expression and kind of like, it's just, we don't know, right? Like how they interact and when to start that intervention. So I'm curious if you can just describe a little bit when you are starting to do that exercise training and what led you to kind of decide at that time frame?
Right. So 2 points there. So the transplant, the only disadvantage of presenting in your office, the phone keeps ringing. But so the transplant was decided based on rodent data. So there has been a number of studies, at least for broadly speaking, so stroke and traumatic brain injury, where they've looked at acute and up to about 2 weeks transplanting the cells to see if there was any beneficial effects. And the field has kind of coalesced around 5 to 7 days as the most appropriate time point to get enhanced engraftment. And so based on that, we have shifted to the 5 to 7 day time point. The rehabilitation paradigm, when to start it, we've kind of gone with the mantra as soon as possible. So the earlier, the better, to try to get gains. I do know that there is potentially some negative effects, but that has been our approach. And again, it is also based on some of the rodent data that we've been looking at. So that's why we're going to attempt to start on day 1 or day 2. So officially, we're going to start on day 1, but we do know that sometimes day 1 they're not able to stand, they're ataxic, and so there will be some variability there.
Well,
So
thank
by
you
2 or 3 days we can get them to stand.
Thank you very much. Great talk and discussion. Our next speaker is George Wittenberg from Pitt, and he's going to talk about a brief introduction to neuromodulatory techniques, including transcranial magnetic stimulation. Thanks, George.
Great, thank you. Just checking everyone can hear me and see the screen, right? Good. All right. It's in my case, the downside of presenting from my living room is that we have a very barky dog who's right now out for a walk, so hopefully it'll be a long one. So yeah, I have 25 minutes to essentially introduce TMS and some other neuromodulatory techniques. Thankfully, there are other speakers who do a much better job for some of them. So I'm going to spend most of it on TMS. And yeah, I've been very enthusiastic about this symposium. I'm happy to be invited to speak. I think that there's a lot of logical sense to the idea of combining the approaches, and we all know that experience is important, and neuromodulatory methods effectively alter the way that experience interacts with the nervous system. You can think of it as really part of the experience-based plasticity that occurs in development and also with learning and after injury. So I'm going to talk about TMS, transcranial magnetic stimulation. As this technique gets older, I think more and more people have heard of it, but I think it's never bad to go over the basics. And then I'll just pick from a few projects that I've done in my lab that have used TMS as an outcome measure. So besides the combination of, for instance, TMS and say stem cells to enhance recovery, it also provides a very quantitative outcome measure that also looks at the mechanisms, for instance, the connection between the motor cortex and the spinal cord. And then a project that I did where we actually used TMS to interact with the practice-related plasticity that serves as a kind of model for a combination of TMS with experience, and then essentially one slide that introduces the other modulatory methods and some of the subsequent talks. So I'm going to, for the sake of time, I'm going to skip the acknowledgements that there were over several years, but it's not a good idea to skip funding. I've been lucky to get some funding from both VA, actually now NSF as well as NIH. And just a brief plug for the American Society of Neurorehabilitation, if attendees are interested in a 3-day program that really looks at the scientific approach to recovery of function and restoration of function after neurologic injury. ASNR is having its annual meeting, at least plans now to be in real life in St. Louis, Missouri in April. All right, so TMS, the principle of TMS is Faraday's law of induction that probably many of you learned at some point during physics. And so it all comes down to this basic equation that the curl or rotation of an electric field in space opposes a change of a magnetic field in time. So this is a vector equation. So it describes the actual geometry of the electric field that goes around the field lines of a magnetic field that's changing in intensity over time. So TMS, there's nothing magical about the magnetic part of it. It's an induced electric field, and we all know that electric fields interact with the nervous system. So the brief history of this. Linda, you had your hand raised, but I don't think there's a question was at this point. So the history is the D'Arsonval spiral. There was a French researcher in the 19th century who used new battery technology to discharge into a coil in which you stood, and he saw flashes of light. Actually, we now know that that sort of stimulation is actually of the retina, although you can actually generate light perception by stimulating the visual cortex. So even though the technology, the methodology was really a 19th century technology, as with many things, the practical application depended on other advancements, not just in technology, but also of thinking. And so the technology improvement was in high voltage solid state electronics. The TMS stimulators of the 50s actually produced a lot of smoke from the very strong electric currents going across gaps and switches in the device. So the first smokeless stimulator was in 1982 in the United Kingdom. And but then the application to actually stimulating the brain came about because of that people were routinely in research, at least, doing transcranial electrical stimulation, and it had the downside that it was painful. So you can stimulate for instance, the motor cortex and produce movements with an electrical pulse over the motor cortex, but a lot of the current goes through the sensory neurons in the scalp, and so you can't do it more than a few times before participants would want to stop. Let's see. So the first stimulator was actually developed first as a painless peripheral nerve stimulator. It's actually only a little bit less painful because you're still stimulating the nerve. That's what you would do with it, and there are pain fibers. But a few years after it was developed for that purpose, it was applied to the brain. So in 1985, also in England, and currently it's used clinically for brain stimulation and has been for decades to measure things like central motor conduction time in disorders like multiple sclerosis and spinal cord injury. However, in general, it's not in the United States. And in fact, there was no FDA-approved indication for TMS until 2008, when it was approved for treatment of depression. And so many of the stimulators that are sold in the United States are actually sold for that indication. Those are repetitive stimulators that modulate areas in the frontal lobes. So some technical things about TMS, because it does involve magnetic fields, and those involve magnetic field lines that are loops. It's not possible to localize stimulation deeply versus superficially, and that may not be strictly speaking completely true, but there are advancements in magnetic field shape, but it's still true that with an external device, the magnetic fields are acting on surface areas that are close to the magnet, and even though you can sometimes stimulate deeper structures with clever geometry, you still have a lot of magnetic field that's going through superficial structures. You can, the typical coils that are used for focal stimulation are these double circular coils, just two windings of copper usually that are in opposite directions. And these produce a kind of magnetic field profile that you see here, where it reaches a maximum at one point, and then further away from the intersection of the coils, it's at roughly half the strength at most. So that produces good localization in terms of where the maximum intensity is. You can make the coils smaller, but then the effects are weaker, and you can get a little better two-dimensional localization. But because there is always a maximum point, and because there are threshold phenomena in the nervous system, you can get hyperacuity in terms of mapping responses by moving the coil, so that just a few millimeters of movement of the coil can give you a very different response, because the maximum area of stimulation is moved over in the brain. So just a little bit about safety issues with TMS. It can produce a few side effects. It can produce headache. That's a common side effect. It's generally self-limited to the session of stimulation. There theoretically can be tissue heating with induced electric fields. It's theoretically very minimal with the current stimulator strengths. There's more and more theoretical work in this area because of MRI, but TMS stimulators, especially the way they're used intermittently, generally won't cause tissue heating. There's interaction with implanted devices and metals, so you'll be inducing currents in different parts of the body. Very typical contraindications in research studies are any implanted devices or electrodes. That's through an abundance of caution. There actually, you can do TMS with deep brain stimulation, with spinal cord stimulation and other devices. You just have to make sure that you know what you're doing, and that's because the magnetic fields tend to fall off with a third power of distance. So if you have a coil on the top of the head, there's very little energy that's going below the neck. There's a risk of seizures. It's a minimal risk with single pulse. It's very hard to know sometimes about if someone's had a seizure who has a neurologic disorder, had TMS, whether it's due to the TMS or the seizures. Again, that's a usual reason for excluding people with seizures. The risk goes up with a variety of parameters that of higher rate stimulation, but there are safety guidelines for avoiding seizures with repetitive TMS. And then there have been older studies that have shown no changes in MRI or cognition in people who are kind of frequent volunteers for TMS studies. All right, so I'm going to talk about TMS as an outcome measure, and start with a easy to understand TMS measure, which is a map of muscle representation in the motor cortex. So and this introduces some of the concepts with TMS as a motor outcome measure. You can measure something called a motor evoked potential, or MEP. In this case, actually, this is a biceps MEP from a very old recording I did, but it's always the same. You have a time series of the potential at the muscle surface. When TMS is given, there's a stimulation artifact. The stimulation is much less than a millisecond, but produces a small stimulation artifact, and then you see in this case, a multiphasic, sometimes biphasic, sometimes triphasic response at the muscle, and you can measure the peak-to-peak amplitude, which represents the best, or certainly the simplest representation of how much the muscle has been activated through the summation of motor units in the muscle. And another concept is that you can determine the threshold, the stimulator output that will produce a response. So when you map, you have to be mapping above that threshold, but not too far above the threshold. In this case, 110% of the motor threshold over a grid on the scalp. These days, we do the grid virtually with stereotactic guidance. These data were from an actual physical grid on a swimming cap that was on the person's head. And then you can represent the peak-to-peak amplitude, the average peak-to-peak amplitude of MEP in this bubble plot. And you can see that with a scalp map, midline being here, you're getting responses, in this case, the extensor digitorum communis muscle, that is maximum at a point, what we call the hot spot, and then falls off monotonically as you go away from that hot spot. So you can measure the center of gravity of the map. It's a very accurate measure of at least the center of the motor representation. And then you can also measure the volume of the map. And the volume would be if these bubbles represented space, and you added up the space within all those bubbles. So it's not a true volume. It's really a measure of the extent and spread of the representation in the cortex. So this method was applied to a study of recovery of motor function after stroke. This was a longitudinal study measuring multiple factors within 10 days after stroke, 1 month and 6 months after stroke. I won't go into the types, it's not really relevant here, but when you can see is just a basic measure of TMS is this threshold. So this is what I mentioned about the stimulator output that gives you some response. In fact, there's actually a definition for what the threshold is. I won't go into it, but below that threshold, you're rarely, if ever, getting any measurable response in the muscles. And the stimulator, the threshold is measured in stimulator output. So the stimulators, all stimulators that you get go to 100. They actually, depending on the coil, represents 100% output that's somewhere around a Tesla or multiple Tesla. So the strength is comparable to an MRI field strength, but over a much localized area for a very brief time. And so you see for these participants with individuals represented by these lines, you see what the threshold was at the first visit, less than 10 days after stroke. So for a group of individuals, it's above 100, meaning there was no motor evoked potential. Some of those individuals who had no potential at 3 months now have measurable thresholds, and in general, those thresholds continue to decline over the subsequent months. So for that particular subset, you can really measure recovery through threshold. However, some people don't recover responses at all, and for other people, the thresholds essentially are unchanging over time. So I mentioned that map volume measure. It's a very accurate measure because it is the result of so many stimulation trials, so which is a good thing. So what you can see is in the people who could measure a map in the first case, who actually had thresholds below 100, their map was relatively small compared to the unaffected side. This is affected and unaffected over the 3 times. The map increases in size by the first month, and then has a trend towards decrease towards normal at 6 months, essentially mirroring a lot of other physiological and imaging results in stroke recovery, which is kind of most abnormal time around a month, and then tending towards the norm as you get to a more chronic state. Obviously, this isn't just in people who you can measure the map, not in people who don't recover, however. But in those people who do have that kind of recovery, and so it's a smaller subset, the map volume change in this case appeared to correlate with a change in a functional measure, the 9-hole peg test, the times measure, so in which negative is better, so getting faster on the task. were in that group that actually had the largest increases in map volume. All right, so I'm going to move on to the use of these TMS map measures to actually study an intervention. So this was some of the same methods applied to the EXCITE trial. So that was a study of constraint-induced therapy. We were able to do this as an add-on to EXCITE, which is at many sites, but we were able to do the TMS measures also at Emory and Ohio State. This was done at Wake Forest. And just to talked about timing and in interventions. This is actually, I think this is still a hot topic, and this is a recent study in PNAS headed by the late Alex Stromerick on the effect of timing on an intervention after stroke. So what you see here is a measure. It's also a time-based measure, the Wolf Motor Function Test time in people who got the intervention early after stroke, in this case between 3 and 9 months, and you see the early intervention had a speed up in their Wolf motor function times, and they retained that at a 4-month follow-up. The late group in this case, by the way, didn't get the intervention at this time period, so they're essentially the control group, and so they didn't appear to change, and there was a difference between the groups. So if you look at the TMS measures, the TMS motor map area, which is equivalent to the volume in this case, the people who had the intervention early had an increase in their map area. The ones who didn't had a sort of trend towards a gradual decline, but there was a significant difference between the groups, with the intervention actually appearing to cause an increase in the map area over compared to the group that didn't have the intervention. There was also the group that had the late intervention also had a change in map area, so that the map area change, these do appear to superimpose, so the map increase, and actually this is a group that had the intervention, now looking at the later intervention. So later we can still produce a map area increase, it's just not as great, although there's no significant difference here. So the summary of that data is that, and yeah, sorry, let me just back up for a second. Sorry, you can still produce the map area change in the late group. That's really the point of the graph. So essentially what I said was correct. So the effect of constraint-induced therapy on TMS maps is actually maybe more in the chronic state, although it can happen in both states. And because of actually a relatively large literature for rehabilitation studies in constraint-induced therapy, this map expansion actually is very reproducible. So it's something that is a measurable response to therapy. However, it doesn't, the map increase, it doesn't always correlate with an increase in function, and that still remains something to work out exactly what it means from the point of view of anatomy, and how it can be used. So those are areas for future research. All right, so some of the remaining gaps in stroke recovery work is what brain areas are responsible for the improvement in motor function. So we tend to focus a lot on the motor cortex because of its connectivity, and it's in primates, and particularly in humans, as the sort of most essential region for at least distal motor function. And so moving forward in time, we've been doing work with robotic rehabilitation, which is effective at producing improvements in motor function, but isn't always adequate either. So the question is, can we enhance robotic rehabilitation with a neuromodulatory method that would include TMS. And so in the paradigm that we used to test this, we had measures of TMS responses in rehabilitation robots at baseline. So we're measuring actually the movements evoked by TMS, not the motor evoked potentials. And then we have people practice movements repetitively and measure the responses to TMS, and then also have retention. So people practice against a spring field. So they're practicing movements that are forceful in one direction, and then the spring field brings them back to the center. So it's the robots provide a nice regimented way to provide practice. We can measure the amplitude of the movements evoked by TMS. You get these kind of looping movements because of the spring field. We can measure where the robot hand arm is moved at the point of maximum velocity. So it represents essentially what kind of motor representation is stimulated by TMS. And we can measure changes in those TMS evoked movements between a baseline and between practice. So we're basically, what we're having people do in this paradigm is actually move in a direction opposite to the TMS evoked movements. Realizing that's a lot in a short talk, but hopefully we can clarify that if there are any questions at the end. So what we did in this case was actually use what you could call low rate TMS. So TMS at 0.1 hertz once every 10 seconds, but combined in a precise timing with the movement that was practiced. And we tried 3 different timings, compared 3 different timings, one during the late reaction time period, about 150 milliseconds after go cue to move the robotic arm. A second in an early movement time that would be triggered by EMG, representing a person's voluntary movement to the target, and then a random that had stimulation at a random time, which was probably the best control for the effective timing, since everyone got the same amount of stimulation, but with stimulation coming at different times during movement. And so these are results of the change that we got, the plasticity that we got with practice. So changes in direction and amplitude. On above is direction, below is amplitude, in the 3 different conditions over 4 different times after they started practicing. And what you see is in all conditions of different timing, combining stimulation and movement, there was essentially a 50% increase in the amplitude of TMS evoked movements. I'm sorry, there's no change in there's a 50-degree change in the direction of movement, whereas amplitude, there was a difference. We got about an 80% increase in amplitude with the pre-movement triggering, and only about a 30% with EMG, with random being sort of in between. So this represents a kind of test of a timing dependent, a spike timing dependent plasticity hypothesis. The results were even more dramatic if you looked at motor evoked potential. So just particularly, we were measuring biceps, triceps, and anterior and posterior deltoid. And just for the sake of time, just focusing on the pre-movement stimulation, you can see that with the same stimulation strength, after combining practice and stimulation, you get this this large increase in motor evoked potential. I think I'll skip this for the sake of timing, but the point is that the MEP results, plasticity, was very different depending on timing. In this case, we didn't. We think that this provides a means to enhance practice effects in stroke. We've actually tested this in some stroke patients with promising results, and are currently looking at a strategy involving stimulation of other motor areas to enhance practice effects after stroke. So I'm going to close with just a brief survey of other neuromodulatory methods. So I introduced the repetitive TMS concept, RTMS. RTMS often just is used to mean stimulation that's at 1 hertz or higher, so higher than what I just described. You can actually modulate the excitability of cortex, and most studied is motor cortex, with inhibitory after effects that last for several minutes to up to an hour with 1 hertz stimulation. It can be facilitatory with 5 to 10 hertz stimulation, and then a method of theta burst stimulation that in some ways is based on a biological rhythm between subcortical and cortical structures. You can elicit both inhibitory and facilitatory effects with less stimulation, but patterns either continuously or intermittently for the 2 different effects. Transcranial electrical stimulation, which I mentioned before in terms of pulses of stimulation, can be done to just activate an area briefly, but now there are a much broader range of stimulation methods available, with the kind of earlier one being direct currents, transcranial direct current stimulation, passing DC currents in the milliamp range through electrodes, where that has a modulatory effect that also can change excitability of underlying structures. Alternating currents that can entrain rhythmicity, and then even noise, a combination of different frequencies of stimulation. There's peripheral stimulation can have a neuromodulatory effect. Dr. Batran is going to talk about that, so I won't steal his thunder on that. But vagal nerve stimulation has become very popular, which he'll describe. There are also paired associative plasticity protocols that combine central and peripheral stimulation, and spinal cord stimulation, which is clinically done for pain, is now being investigated for its modulatory effects on motor function, and it's really a very exciting area. The reflex or other conditioning, Dr. Wolpaz is going to talk about. And then there are other developing methods involving focused ultrasounds and deep brain stimulation, which has been around for a while in movement disorders, is now, I think, being explored for its modulatory effects. So with that, I'll stop and see if there are any questions.
Thank you, George. Any questions? Just hit the raise the hand. It was a very complete talk, so maybe there are no questions.
Well,
You've left us questionless. That was a great description.
I think
there is a question.
That's right.
Are changes described with TMS retained? Is a question in the chat.
Right, that's a good question. So I think that refers to our plasticity paradigm, right? So in paradigms like that, that's sort of practice-related plasticity, the changes are retained, on the order of 20 to 30 minutes, right? So it's and these are single sessions. So I think, and this actually I think represents it's a good question because it points to the strategy, which is I think for these single session effects, if you get something that lasts for 20 minutes, you're happy. I think just like in therapy, it will probably require repeated sessions to get consolidation of useful changes. This is a kind of model for plasticity. TMS evoked responses, as I think some people would be very quick to point out. It doesn't represent the change in voluntary function, but we hope that it's a model for improving voluntary function over a longer time course. Thanks.
Okay, thank you very much. Our next speaker is Bashar Badran from the Medical University of South Carolina. If you can see me in the corner, if you ever attend one of his things, you can actually get an ear USB connector. He'll make it personally for you, right, Bashar?
If you want it, we'll make it. That's our
Take it away.
Thanks, Rick and George, for inviting me. And So yes, I'm Bashar Badrian. I'm assistant professor of psychiatry in the brain stimulation division at the Medical University of South Carolina. Today, I'm coming to you live from actually Columbia University in the New York State Psychiatric Institute, where I'm actually double booked. So I'm sorry I've missed the beginning, and we'll have to miss the end of this nice symposium, but the schedule looks great, and I hope everybody's learning a lot today. I have a short time slot here to tell you pretty much what I could fit into a 2-hour lecture. So consider this a highlight reel of non-invasive vagus nerve stimulation. Now, if you have any questions after, or want to meet one-on-one or over Zoom, just shoot me an email. That's my last name at musc.edu, and I'll get back to you. I try to respond to everyone. So here are my disclosures. I have ownership stake in a couple startups and serve as a consultant or medical advisory board member for several companies and institutions, and have received some donations for equipment and filed and have pending patents on a lot of this stuff. But getting right into it, the vagus nerve is actually cranial nerve number 10. It's the largest nerve in your body. And it's not just a single nerve as you would imagine. It's actually a bundle of nerves. So it's 100,000 axons. And so on the right, you could see a cross section of the vagus nerve, and you can see all the myelinated and unmyelinated axons here wrapped in gristle that communicate signals from your brainstem to every organ in your body. So I like to tell people that your eyes see, your smell comes from your nose, you can hear from your ears, you can taste in your tongue, and everything else is vagus. And so the majority of your parasympathetic nervous system, or the slowing effects, so relaxation, reductions in respiration rate and heart rate, are all mediated by activating the vagus nerve and are cholinergic efferent projections from your brain. Now, in the 80s, they actually developed a technology known as vagus nerve stimulation. It was actually created by Professor Jake Zabara at Temple. And what you can do is implant a vagus nerve stimulator in your chest. And on the bottom right here in this picture shows the pulse generator, which is a computer and a microcircuit and a stimulator and a battery all in one. That lasts about 5 years, and it connects to a cuff electrode on your left bundle of your vagus nerve and delivers stimulation to the nerve tonically over 5 years. And it works pretty well in treating intractable epilepsy that's not responsive to conventional antiepileptics. It also is being re-explored as a treatment for depression and had early indication for chronic recurrent depression. It's pretty safe, except there's a few drawbacks. The first is it's invasive. The onset of action is 6 months to a year. There's only about a 33% response rate. If there's any complications, you require another surgery, and it can be expensive. So what we've been working on is non-invasive vagus nerve stimulation. So on the left, you could see that the human auricle has a high density of nerve projections from body. And in green here is actually the distal projection of the auricular branch of the vagus nerve, or the ABVN for short. And it innervates the symbicontia region of the ear, the external auditory meatus, and the anterior and posterior walls of the outer ear canal. So this entire area is a ripe, biologically active area that's sensitive to electrical stimulation. So when we stimulate the auricular branch of the vagus nerve, we actually call this transcutaneous auricular vagus nerve stimulation, or taVNS for short. Now, you may be wondering how we do this. We recently published a nice manuscript that shows how you can actually use MRI, high resolution MRI, to create computer models of the anatomical underpinnings of the human auricle, where we can segment the skin and the fat, cartilage, muscle, skull, and brain, and then create some ear regions of interest here that help us determine where to optimally place the electrodes to activate the auricular branch of the vagus nerve using electricity. So you can come up with a variety of different montages. In fact, some may say an infinite number of montages, although, to be short, we stuck to 10 For the record, we actually use Montage 6 in a lot of my clinical translational studies, although we started with Montage 1 nearly 10 years ago when we started this body of research. And as you can see, if we place electrodes on the ear and then do some modeling of the electrical current projections of these montages, you can see that the more dark red areas represent increases in electrical field locally. And so what we use is Montage 6 here, which activates the Cymboconcha region and the anterior wall of the outer ear canal simultaneously. And as you increase current, you get greater activation in these nerves. So because we can't individually map the underlying anatomy of all of the nerves in individuals and specifically target one nerve, we take more of a shotgun approach and try to electrify the ear in a pattern that may optimally, on a group level, activate everybody's ABVN, knowing and conceding that if the innervation is not in this area, we may be off target. And if you're interested, you can look up a pretty cool Jove article we did. Some of the methods are outdated, but taVNS is relatively inexpensive. It needs a conductor and an electrode and maybe a computer and a stimulator. So you can get yourselves one of these setups for less than $1,000, although the systems that we use generally cost between $4,000 and $5,000. Now, the early studies that we conducted in my lab were to determine the parametric effects of taVNS. So perhaps you can use autonomics, like immediate beat-to-beat heart rate, as a biomarker of vagus activation, since the vagus connects the brain to the heart. And we picked 9 different parameters of varying pulse widths and frequencies, and showed that as you increase the pulse width and increase the frequency and give a more dense level of electrical stimulation, you get larger effects on heart rate, which after you turn stimulation off, result in a sympathetic recovery. So you don't only get parasympathetic activation during stimulation, you get a sympathetic recovery after you turn off stimulation, which shows that we're really pushing and pulling autonomics in healthy individuals. And this was published in Brain Stimulation. The follow-up question was whether auricular VNS activates the vagal afferent network. So what we've done and have at MUSC is one of the few setups in the United States to deliver auricular VNS combined with functional neuroimaging. And what we have is MRI compatible electrodes and a system that, I'll spare you the details, allows for time synchronized administration of auricular VNS during functional neuroimaging. And as you can see here on the left, and this is also published and you can look it up, the auricular VNS profile is different than the sham stimulation profile. So what you're seeing here in figure A is the activation, neurophysiological activation profile of sham stimulation, which is actually delivering the same electrical waveform and the same parameters to the earlobe. And when you do that, you get bold increases in the contralateral somatosensory cortex. But if you move the electrodes up to target the Cymboconcha and the tragus, which are ABVN targets, you actually activate the vagal afferent network, including the prefrontal cortex, the insula, thalamus, and cerebellum. And you can actually remove the sham effect from the active effect, because the active effect also has a robust somatosensory signal, so that you can end up with the ABVN derived brain signature here, which is a bilateral activation of the anterior cingulate, insula, thalamus, and cerebellum. Now, after we determine both the autonomic and central effects, and over the same period of time, determine that it's safe, it mimics implanted VNS, and we optimize the parameters, we went on to run a series of clinical trials. Most of these are still ongoing in derivative longitudinal studies. But what we have done is created a system that facilitates neuroplasticity and enhances motor function when paired with motor training. So we enrolled a cohort of neonates who have difficulty feeding and sucking on a bottle. These babies unfortunately end up getting surgical implantation of a gastrostomy tube because they can't feed and need to be fed by a port. So before they get surgical implantation, we pair auricular VNS with bottle feeding training and are able to restore deficits that they have in motor function and allow them to learn quickly how to suck on a bottle and end up going home without a surgery. So this is pretty amazing technology and was recently awarded an FDA breakthrough device designation. We recently were awarded an NIH grant to follow this up, and this is another faculty startup of ours. Furthermore, funded by the MUSC Center for Stroke Recovery and the COBRI, we actually are funded to do motor activated auricular VNS, or MAVENS, which is a system where we use EMG sensors that closed loop initiate auricular VNS during task-specific practice administered by an occupational therapist during post-stroke motor rehabilitation. This therapy is being tested now in a 4-week trial where individuals come in 3 times a week for 4 weeks and receive MAVENS to help accelerate the restoration of their upper extremity motor deficit. Here's a couple of videos.
Okay, go ahead, and left arm.
This woman actually has her right arm affected, and when she moves her right arm,
Relax.
you could see the stimulation light
Stay
actually
still for
turn
a
on.
second.
When she's still
Okay, left
or
arm.
engaging her left arm, which is her unaffected limb,
Right arm.
no stimulation is initiated. So it's quite selective and sensitive and works really well. You also can conduct this not only seated, but standing. And this is a video of one of our participants putting as part of his therapy. And so this is a mobile, freely active. You can walk, you can do all sorts of activities while receiving it. It's lightweight and it's very safe. We also have some studies using the taVNS setup to reduce fatigue in patients with long COVID. And with that, I want to be respectful of everybody's time and say thanks. And we're at the NeuroX Lab at MUSC, where we create disruptive technology and new wearables that help change the world. So these are some of my students, staff, and trainees, and some of our sponsors and funders. So thank you so much, and I'll take some questions.
Please raise your hand, and well, I'll raise my hand without raising my hand, Bashar. How quickly do you think this people could be trained to apply this? You know, these trials you have going now are really inviting, and particularly with the babies. And I can see people getting very enthusiastic about this. I mean, what do you have as a vision of really trying to push this out to a large clinical group that knows what they're doing because of your excellent training?
Well, you know, I'll give you an example why we're here in New York. We're launching a pretty large study right now where we're doing, where we are doing auricular VNS for fatigue, for patients with fatigue who have chronic Lyme disease symptoms. And this is an at-home neuromodulatory intervention where people will come in, check out a stimulator, and self-administer stimulation for 4 weeks. From what we've seen in both the COVID study and this trial, along with others, people are trained in one session. We've worked really hard to make handheld stimulation devices that are easy to use. So you place some stickers on your ear, you plug them into a little handheld device that's as big as an iPhone, and you hit start. We give you codes. These devices are blinded and are really simple and easy to use. They have built-in timers, and they time the whole session. And we can confirm folks actually using their systems and adherence because it generates information that comes back to the researchers. So, you know, in my opinion, these are very easy to use. We're at a time where we're rapidly accelerating this at home. But even in the rehabilitation setting, an occupational therapist who's untrained in brain stimulation can set up a patient pretty quickly with minimal training. So that's what makes it really appealing. not only its benefits are great and it's relatively inexpensive, but it's easy to use and it's a non-significant risk device. So I think that's why everyone's excited about it.
So one last question. I'm going to ask another one. Somebody else put their hand up. So there's evidence in animal models, as I understand it, that vagal nerve stimulation may potentially have some impact on Parkinsonian animal models. And of course, transplantation is also something that's been explored in Parkinson's, which I would say is related to our meeting today when we're talking about regenerative medicine. Any update on how those kinds of studies are going?
I think it's a great question, Rick. I think you're alluding to our ongoing clinical trials where, you know, there's this newly emerging norepinephrine mechanism underlying Parkinson's disease. And it's not only simply the dopaminergic pathway, but perhaps a precursor norepinephrine pathway that may be involved, which makes VNS really appealing because VNS enters at the brainstem and when you turn stimulation on, it reliably activates the norepinephrine molecule release. So that said, we've been doing ongoing double-blind clinical trials in Parkinson's. It's still unblinded. There does seem to be a difference between groups, so I'm not sure exactly where that is. All the animal models, though, look really good. So a first author on the animal work is Heather Boger. So if anyone's interested in that, you should go check it out.
Heather's on the executive committee for NM4R. There's a question in the chat, and then when do you apply the stimulation? At the movement onset or during movement or at the end of movement? Was that related to Bashar's?
Yeah, it's initiated with the movement initiates stimulation. So it's simultaneously at initiation of movement, and it's within 100 milliseconds. Although some animal studies suggest that it doesn't need to be that tight. Perhaps within 2 seconds may be sufficient, but we like to be thorough. So it's as tight as possible to the initiation.
Any other questions from the audience? It's very excellent talk. Stimulate. I hate to use that. I said stimulating talk. But be sure to contact Bashar if you have any questions. If you need his contact information, he gave it to, and we can also get it to you. So thank you very much. We're going to take a 5-minute break because this is Zoom and people need to stretch. And enjoy the rest of your time in New York, Bashar.
Thank you so much, guys. Rick, George, appreciate the invitation. Take care, everyone.
We'll be back. It's 3:21. Let's pick up at 3:26. We'll be resuming in just a moment. I think John is he's put his savings account numbers on the screen for us. Everybody pay attention.
Yeah, thanks, Rick.
So without further ado, I'd like to introduce our next speaker, John Wolpaw, from the National Center for Adaptive Neurotechnologies up in New York, and also at the Albany Stratton VA Medical Center. John has been working in this area for a long time. I'm not going to say how many years, but it was prior to our 1988 conversation that he started this. So without any further ado, I'd like to introduce John Wolpaw, who's been thinking about this for years. So John, take it away.
Okay, great. You can hear me okay?
Yep.
Okay, great. So thanks, Rick. Yeah, Rick has been involved with this for many years now too. Back in the 80s, he was one of literally 4 people in the world who cared at all about what I was doing. And there are actually still only 2 of them are still around, Rick and Steve Wolf. So I'm very glad that he was able to introduce me to this, and we'll see what has developed in our joint work over the past 40 years. I want to thank everybody for the opportunity to talk here. Both everyone really at AR3T and NM4R, George and Rick and Steve and Michelle and Blair and everyone else involved. It's great. I know a number of you in the audience heard me talk about a week or so ago, but rest assured, though this starts out somewhat similarly, it gets considerably different as we move along. And it is different, and it's also different because things have advanced since in the last week or so. This is now really a very fast-moving field. So I'm supposed to talk about the work that we've done in operant conditioning and other people have done, really targeting plasticity and related really to neuromodulation. And I'm doing that under the rubric of neurorehabilitation in the 21st century, targeting, which is what I've been mainly concerned with, and neuromodulation, which I'm referring to it as enabling plasticity. So So 50 years ago, I think as some of the more elderly people such as myself here know, rehab research was Dullsville. Now the scientific insights it produces and the therapeutic opportunities it creates make rehab research one of the most exciting areas of neuroscience. So I think, are people seeing the whole screen, or are there some, are the pictures over on the side? I guess they are. Okay, so the reason for that is that we now know that the CNS has ubiquitous plasticity throughout life. There's neurogenesis, gene activation, neuronal properties change. There's long-term potentiation and depression at synapses, glia change, dendrites change, hormones change. There's sprouting, there are vascular changes. All of these things throughout our lives combine to enable us to acquire and maintain adaptive behaviors. So basically, that's what the nervous system is doing mainly, is by our current understanding. So for rehabilitation, yeah. Oh. Trying to get rid of the sharing. Okay. We know that the CNS changes continually throughout life. For rehabilitation, the problem is to take all these various kinds of plasticity The challenge for rehabilitation is to take all these various kinds of plasticity and to somehow figure out how to use them, to guide them, to induce them to produce recovered behaviors. There are three major insights over the past 50 years that have now made it possible to do that, or to understand how to do that, to at least to begin with. First, the first insight is that even the simplest behaviors are learned. For example, flexion withdrawal reflexes, it's now clear, are learned early in life. This is shown here in a study by Levinson et al., now about 20 years ago. This is a normal rat with a painful stimulus occurring. When a painful stimulation occurs somewhere on the limb moves away from the painful stimulus. However, if the rat has had a neonatal spinal cord transection, when it grows up, often the limb will move toward the stimulus. So this is an abnormal flexion withdrawal response. It hasn't completed the learning process early in life. And in that, it's guided by the brain. There's spinal cord changes that are guided by the brain early in life. This is another example. In a normal infant, when you stretch a muscle, you get responses both in the agonist muscle, which is the solid, and in the antagonist muscle, which is the dotted. In a normal adult, all you get really are responses in the muscle that was stretched, not in its antagonist. However, if the person has had neonatal damage, cerebral palsy, you can see the preservation of the abnormal response in the antagonist muscle as well. So this is an example of the failure of the normal learning process, activity-dependent learning process to occur. So the second major insight is that each behavior is produced by a widely distributed substrate of neurons and synapses. This we're now calling, and this is a new word, a Hexer. A Hexer is a distributed network of neurons and synapses that produces a behavior. So this is a study about 5 years ago by Badat et al. An fMRI study showing the sites of plasticity that underlie the acquisition of skill in a simple finger flexion task. And you see, as this skill is acquired, the acquisition of skill is explained by plasticity in the cortex and in the cerebellum and subcortical and other places subcortically, and also in the spinal cord. So here you see the plasticity that is responsible for the acquisition of the skill, the overlapping parts and the independent parts, cortical, subcortical, and spinal. All these areas combine to produce the skill. So this is a distributed pattern of plasticity. Here's another example that we've spent a lot of time looking at over the past 40 years, operant conditioning of the H reflex, which is the electrical analog of the spinal stretch reflex. It's produced by largely by a 2-neuron reflex arc. And it's called the H reflex because Hoffman described it something over 100 years ago. It's under the influence, however, of descending control pathways. So using that influence, by operant conditioning that influence, we've shown that monkeys, and others have shown, is that monkeys, rats, mice, and people can gradually change H reflex size when they're rewarded for doing so. And this shows the phenomenon in rats trained up or down over a period of 50 days. This is the same, pretty much same, that was originally demonstrated by Shun-Yun Chen in our lab, and this is by Iko Thompson in humans, showing the very similar phenomenon. These are people this is all entirely non-invasive in people. These are 3 one-hour sessions per week, people who are trained up over 8 or 10 weeks, and people who are trained down. And months later, the change persists. So this is the phenomenon of H reflex conditioning. We've spent a lot of time looking at the basis of this, the network of neurons and synapses that's responsible for it. It's clear that there's a widely distributed network of brain and spinal plasticity. These are the people primarily responsible: Shun-Yun Chen, Yu Wang, Jonathan Karp, Lu Chen, and Yi Chen. And this is a current understanding of what happens, what's responsible for H reflex decrease in down conditioning. You have a reward, which affects the inferior olive, which produces activity reaching the cerebellum that leads to plasticity, shown by this pink blob in the cerebellum, which gradually leads to plasticity in sensory motor cortex. Actually, this occurs over about 1,000 trials in monkeys and also in humans. And it changes some aspect of corticospinal tract activity, and that produces a small appropriate decrease in the H reflex. And that stays in effect over days and weeks in the humans over many sessions, and it gradually produces plasticity at multiple sites in the spinal cord. And that is responsible for much greater decrease in the H reflex. So plasticity in the brain guides and maintains plasticity in the spinal cord. So this is another distributed network of neurons and synapses responsible for an ostensibly simple adaptive behavior. So these are Hexers. The Hexer responsible for motor sequence learning, finger flexion sequence learning, and the Hexer responsible for H reflex conditioning. And the name comes from a classical root that was courtesy of Adam Commissar, who's a classical scholar. It has a very appropriate origin in a Greek word called hexus, which over 2,000 years ago explained something very similar to what we're trying to explain here. So the word basically was there waiting for us to use it. And from that, we derived, through a fairly complicated process, the word hexor. So the third insight, and probably the most consequential, is that Hexers share neurons and synapses. Thus, when a learning experience creates a new Hexer, old Hexers change, they adapt to maintain the key features of their behaviors. Now, these are the key features of adaptive behavior, are the features that make the behavior satisfactory. For H reflex conditioning, it's very simple, that the size satisfies criterion. It's below for down conditioning, or it's above the criterion for up conditioning. For flexion withdrawal reflex, it's also simple. Then the fingertip is supposed to rapidly withdraw from the hot stove. And it doesn't matter whether that's been done by finger extension or by wrist extension or by elbow movement or shoulder movement or the whole body movement. The point is that the key feature is that the finger get off the stove very quickly. For locomotion, there are obviously many key features: right-left symmetry, vertical posture, adequate balance, acceptable metabolic cost, and others. EMG and kinematics can change, but key features are maintained. Hexers share neurons and synapses, thus they affect each other. This is an example. This was a study done by Sacco et al. Something over 10 years ago. They trained people on a simple foot flexion extension behavior and recorded fMRI while they were doing it. They then trained them over a week or so on a dance behavior that obviously involves some of the same neurons and synapses. And then they had them again perform the foot flexion extension behavior and again recorded fMRI. And they then looked at the difference between the fMRI here and the fMRI here. And these are the sites of difference. For example, there are differences in leg areas of cortex. There are differences also subcortically in cerebellum. There are also differences in connectivity between cortical and subcortical areas. So basically, this performance is the same here and here, but it's being performed differently, presumably because the changes with the acquisition of this dance behavior, this new Hexer, have compelled changes in the old Hexer to preserve its key features. This is another example. People who speak one language, these are the major areas of activity associated with articulation and for word retrieval. These change, they get larger and more complicated. These are the areas of difference for people who have a second language. Again, the acquisition of the second language changes how the first language is achieved. And when you think about languages, you can imagine many reasons why that would be so. So this is a empty nervous system that hasn't learned anything. It has many neurons and synapses, many properties of these neurons and synapses that could conceivably change, all these deltas. In utero and early in life, it acquires a flexion withdrawal Hexer, and this changes a certain set of properties, certain set of neurons and synapses. A little later, walking is acquired, and that changes an overlapping set. but the changes in these compel further changes in these so that they can still combine to produce appropriate flexion withdrawal responses. And similarly, when later on in life another skill is achieved, the picture becomes more complicated. But all these sites basically are reflecting all three of the behaviors, all three of these hexers. So a hexer is like a person with one goal in life, to maintain one behavior. Hexers are changing concurrently because they share neurons and synapses. Each is continually responding to what others have done. The aggregate process is a negotiation. Hexers keep the CNS in a negotiated equilibrium that serves them all. A new hexer expands the negotiation, old hexers change in response. In the new negotiated equilibrium, each hexer maintains its key features. And you can see these similar changes also. I've emphasized how one hexer, a new hexer, affects old hexers. Other things obviously affect hexers: aging, initial growth, aging, changes in weight, other kinds of injuries. All these things are going to require changes in hexers to maintain their key features. So the CNS throughout life is normally maintained in a state of negotiated equilibrium. So a hexer is a distributed network of neurons and synapses that produces a behavior and changes as needed to maintain the key features of the behavior. This was presaged now in the middle of the 20th century by Bernstein, who said that behaviors are biodynamic structures that live and develop. That's what hexers are. So the goal of neurorehabilitation in this context is to make it possible for damaged hexers to achieve a negotiated equilibrium in which each hexer can maximize restoration of its key features. There's clearly a new promise with our knowledge of the ubiquitous CNS plasticity throughout life. The CNS can change in many ways through life. There are many possibilities for restoring function. However, there's also a new problem. There are many kinds of plasticity and there are many locations. Each has its own local mechanism, requirements, rate, etc. It's controlled indirectly or maybe not at all by its behavioral impact. There's no overall direction. There's no little person in the head who, when damage occurs, is going to figure out the best possible sequence and pattern of plasticity. There's no guarantee of optimal plasticity to achieve optimal recovery of function. Thus, the system can get stuck in a local minimum. Potentially beneficial mechanisms are not engaged. So, thinking about how we address this problem, if we look at the spectrum of plasticity, and there are all these various ways of interacting with the nervous system to produce changes. They go from very focused plasticity at very specific sites to widespread plasticity. And when we look at the acquisition of adaptive behaviors in the normal nervous system, that's kind of in the middle. Yes, it's not completely widespread, obviously, at certain areas, but it can be highly variable, that the same behavior can be achieved in different ways, different combinations of EMG and kinematics across different people, different combinations in the same person throughout life, etc. So there's imprecision here in exactly what's necessary, and you can still achieve the same adaptive behaviors. So similarly, in the standard therapeutic spectrum, the mainstay of behavior is therapy is behavior-specific practice. And again, this is not entirely non-specific, but it's not specific enough to ensure optimal plasticity. There are many ways that behavior might be improved, and it isn't clear after an injury that the best pattern or the sequence of plasticity will occur. There are just too many possibilities, too many different mechanisms and sites involved. So the rehabilitation of the mainstay of rehabilitation has been behavior-specific practice, but these behaviors are complex. There are many possible mechanisms and sites of plasticity. How do we ensure optimal engagement of the many kinds of sites of potential plasticity? There are two strategies I want to talk about, basically targeting and enabling. And this is where I get to the, say, operant conditioning versus various neuromodulation methods. So this is the new therapeutic spectrum. We have focused training, focused stimulation, which is targeting plasticity to critical locations. And then we have neuromodulatory techniques, TDCS, VNS, electrical stimulation of the spinal cord that enable plasticity. They speed plasticity, or they access methods or mechanisms that are not otherwise available. This would be, for example, a drug or a implant or a transplant that would reactivate axonal plasticity in the spinal cord. All these I see as neuromodulation methods. So you have these two possible approaches, and really strategy, both these approaches are logically combined with behavior-specific practice. Strategy one is targeting with behavior-specific practice, and strategy two is neuromodulation plus behavior-specific practice. And obviously our focus has been primarily strategy one. And that began now, as Rick was saying, quite a while ago in the late 70s, looking at initially operant conditioning of the monkey. This was for basic science purposes, the monkey stretch reflex, and moving on to the H reflex, showing that this phenomenon could occur, and then using the H reflex and the rat particularly to look at the underlying mechanisms. And then it was only about 20 years ago that we started taking these techniques and seeing if they could be put to therapeutic use. First, we showed that we found that rats with spinal cord injuries could learn to walk better with appropriate operant conditioning. And Iko Thompson went on to show in people with spinal cord injury that would also occur. And we and others are now looking into helping people with strokes as well as other disorders with various kinds of operant conditioning, not simply H reflex. This is really the therapeutic approach of targeted neuroplasticity. So the idea is to create a new Hexer that targets plasticity to a critical site. The change enables effective practice. It can remove a roadblock that promotes negotiation. It enables effective practice that then promotes negotiation that leads to much wider beneficial plasticity. And this is a cartoon that's showing how a simple new therapeutic Hexer can improve a damaged Hexer. Here you have the nervous system that's learned to walk. You have an injury such as a spinal cord injury, producing abnormalities in many places and very disordered locomotion. You go into a critical site with, for example, H reflex down conditioning that compels a beneficial change at that site, because that's all this Hexer cares about. It has one key feature. It's a therapeutic Hexer that has one key feature, and it compels change at this site. And this enables the damaged locomotion Hexer to practice better. There's better negotiation, and you get much more general improvement, widespread improvement that you would get without this. And this is illustrated simply here in work from Iko's lab. This is an uninjured person walking along, and this shows the activity in soleus and tibialis anterior, as well as the H reflex excitability over the step cycle. So this is in an uninjured person. You have the soleus burst during stance. Soleus is quiet during swing. You have tibialis anterior activity that's high during swing, and it's particularly high right at the onset of stance, keeping the toe up. And the H reflex is very inactive over the swing period. This is in contrast to a person with a spinal cord injury. You have clonic activity in the soleus. You have absence of the critical tibialis anterior activity that keeps the toe up. So this person has clonic activity instead of a normal stance period, and it stumbles because of toe drop. And the H reflex is way too big during the swing period. If you can decrease that, if you can decrease the abnormal H reflex, you start to see a somewhat normal looking soleus burst, and you can see now the onset of appropriate TA activity keeping the toe up, and the H reflex is a lot less active during the swing period. So all that was done was to decrease the abnormal soleus H reflex. And clearly the TA was affected beneficially. This is in another patient, one of Aiko's initial patients. This is before that the activity, the locomotor related activity and the soleus, TA, vastus lateralis, and biceps femoris of both legs before, which is the dashed, and after the blue solid, conditioning, down conditioning of the soleus muscle. So the abnormally high soleus H reflex. After down conditioning, the soleus burst is bigger on both sides. The TA activity is more appropriate, and the activity, there's more locomotor activity also in the vastus lateralis and biceps femoris of both legs. And this is particularly really interesting to look at, because clearly this is an increase in the stance burst. This is not a direct effect of decreasing the soleus H reflex. It's an effect of removing a roadblock, which allowed wider beneficial plasticity and improved negotiation with the practice it therefore allowed. And as a result, people walk about 60% faster, and they walk more symmetrically. The right-left time becomes very close to the left-right time. The ratio between the two should be 1, otherwise the person's limping, and that's what occurs. It becomes close to 1. So the strategy is targeted neuroplasticity plus practice. A therapeutic Hexer or another targeted intervention, such as the paired pulse stimulation that Monica Perez has pioneered, leads to beneficial targeted neuroplasticity, which enables better practice, which improves negotiation, which leads to widespread beneficial plasticity, which leads to enhanced recovery. So these are examples here from Aiko's lab. This is a man who actually has gone through several cycles of operant conditioning of various critical sites. This is 5 years after a spinal cord injury. This is before several months of down conditioning of an abnormally high H reflex. So here he is walking before, and here he is walking afterwards. And the first thing you notice is that before, he's got somebody standing next to him because he's unstable. He's got a wheelchair behind him in case he has to sit down. He's got stoppers on the walker, whereas over here, he has tennis balls on the walker because he doesn't need as much support. And there's nobody around him, and there's no wheelchair behind him. And he's walking the same fixed distance, but he's walking it 3 times as fast. So this is the result of just down conditioning an abnormal soleus H reflex in one leg. So he's done here and he's still going here. This is another example. This is now a person with a stroke 2.5 years earlier who was exposed to another targeted neuroplasticity therapy, operant conditioning of corticospinal tract connections. And this is, she's doing the standard box and blocks task before and after the several months of conditioning. The job is to take as many blocks as fast as possible from this side and move them to that side. And there she goes. This is how many blocks she's doing prior to the therapy, and this is afterwards. She's going at least twice as fast afterwards. So that's the targeted neuroplasticity plus practice. Here is the other end of the spectrum, enabling plasticity or neuromodulation. So here the strategy is to create new options for plasticity, and thereby provide the damaged Hexers with new opportunities for negotiation. The practice then enables the Hexers to negotiate more effectively and better restore their key features. It basically provides a wider field, additional opportunities for them to interact to create beneficial plasticity. So we really here now have target, and you've been hearing in this over today, the benefits of doing that, which are now becoming clear. So we have really the two ends of the spectrum, targeting plasticity, leading to a therapeutic, producing a therapeutic hexer that removes a roadblock, which enables better practice, which leads to better, with the ability to practice behavior, improve negotiation, widespread plasticity, and in better recovery. The other end, we have enabling plasticity, stimulation or other agent, that enables plasticity, that provides more negotiation options and thus more extensive, potentially beneficial practice, improved negotiation, and widespread plasticity and better recovery. Now, these two ends of the spectrum have differences, both have specific advantages and disadvantages. Targeting requires that the therapist know what to target. Sometimes this is obvious, as it was with the hyperactive H reflex. Sometimes it is not. Somewhat reassuring in this is that in rats with spinal cord injuries, we tried to do the wrong kind of conditioning. And I don't have time to go into that, but basically in those animals, performance did not get worse. It didn't get better, but it didn't get worse. And it was clear looking at the EMG, et cetera, why. The locomotion hexer, which was damaged, adapted so that locomotion did not get worse. For example, when rats get better when the H reflex is trained up because their stance is weak. When we tried to train it down, it didn't go down. The soleus burst did not go down, which it normally would have done. So the locomotion hexer was adjusting, was providing additional excitatory input to prevent the further decrease. It couldn't get better, but it could prevent further worsening. But it's not clear that that would always be the case. So targeting has that issue. You have to really want to know what to target. Now, in contrast, enabling leaves the decision to the hexers of what to change, which in principle, they're best qualified to choose. But damaged hexers often fail to choose optimally in spontaneous recovery. They may fail also when they're offered additional options. Therapy protocols that combine both targeting and enabling with behavior-specific practice may be most effective. So this may be the new therapeutic spectrum, may ultimately come to be combined strategies using all three of these methods of creating beneficial plasticity. So in summary, there's lifelong CNS plasticity that challenges to use it to restore behaviors. The substrate of behavior is distributed from brain to spinal cord. It's now called a hexer. Hexers share the CNS. They affect each other. Each changes continually to maintain the key features of its behavior. They keep the CNS in a negotiated equilibrium that serves them all. The goal of neurorehab is to help damaged hexers restore a satisfactory negotiated equilibrium. A first strategy that comes out of that is a therapeutic hexer or other intervention that targets beneficial plasticity, improves practice, and thus it improves negotiation. The second strategy is an intervention that enables plasticity, a neuromodulatory intervention, increases negotiation options, and thus makes practice more effective. Both strategies produce widespread beneficial plasticity that enhances recovery. The best protocols may combine both strategies with behavior-specific practice. So these are the personnel of NCAN. I pointed out particularly the people who have contributed most to what I've been talking about. Our support from NIH, from the Department of Veterans Affairs, and other organizations. Thank you. Look forward to your questions and comments.
We have a few questions about hexers. Just one, you're talking about damaged hexers. Just wanted to throw this in right away. What about you have a transplant put in a spinal cord or someplace else? Is that part, how does that fit into your model?
Well,
So
that fits in by, if it's effective, that it provides additional options. If it manages to induce the damaged tissue to have additional capabilities, or if it integrates itself into the damaged tissue, it provides additional opportunities. It provides additional opportunities for plasticity and thus additional opportunities for Hexers to interact, to negotiate, to improve their defective performance behaviors.
So your operant conditioning would be a way to try to help correct the Hexers.
Yes, I mean, I think what you're going to need, and I think it's becoming clear, and obviously there are people here that know a lot more about the best ways to use neuromodulation than I do, but that you need to combine it with practice. You need to combine it with some more than just doing the stimulation or the neuromodulation. It needs to be used. It provides opportunities, but they need to be accessed. And what happens is ideally they will be taken advantage of by the damaged Hexers and used beneficially by them. It just increases their options.
In the chat we have, do you have any suggested experiments, simulations to test the existence? And then following that question is, are Hexers a thing? That is, are they more like latent variables in dimensionality reduction analysis, or do they represent a basic biological mechanism?
Okay, right. We do have a lot of ideas about how you would go about detecting them. And clearly, we've done a lot with the H reflex and locomotion interactions that support it. I don't have time to go into all of that. And there are some confirmatory, there are other kinds of, now particularly in humans, fMRI studies that are consistent with them, but there's a lot of work to be done. And it's very clear that other behaviors have to be looked at. There are potentially ways, even in people, to use EEG and other kinds of imaging methods to hopefully be able to detect them, and maybe be able to detect them in action normally as well as in pathological situations. So, but that's something that has to be looked into. Clearly, they have to be tested. It has to be checked. There are predictions that are made. The general prediction that the whole idea of Hexer negotiate equilibrium makes is that when you acquire a new behavior, when theoretically a new Hexer is produced, the plasticity, the changes that occur, the plasticity that you can detect in the nervous system really falls into two classes. The plasticity that is the new Hexer, the changes in neurons and synapses that's responsible for the new behavior, and the plasticity, the changes in neurons and synapses that preserves the old behaviors, the adaptations they make. And you can see that affected. You can see that now. The evidence we have for that now is that you see very different changes in the damaged nervous system when you make it better with a new Hexer than you do in the damaged nervous system when you try to make it worse with a new Hexer, and very different from what you see in the normal nervous system, the uninjured nervous system, when it acquires a new behavior. And those findings, at least in the H reflex and locomotion, are completely consistent with the idea. But clearly it has to be looked at in other situations, and there are ways of doing that. In terms of these being a thing, this is as Bernstein described, a biodynamic, the idea is this is a biodynamic structure that lives and develops. And it will have, it does not, so kinematics and EMG change. The details of a behavior can change. There are many variables that can change, but there are certain variables that are maintained, and those are the ones that make it satisfactory. And I went into that a little bit with a flexion withdrawal response. It's obviously easiest to think about it with simple things like that. All you care about is that the finger get away from the stove fast. And you really don't care what muscles and what angles and what sequence do that, as long as that occurs.
Yep.
That's the one key feature that has to be preserved. So there's a lot more to say about this, obviously, but that's a start, I think.
We have time for one more question. Anybody have a question? You can put your hand up or put in the chat. Okay. Thank you, John.
Okay, thank you.
Our next speaker is somebody that AR3T and NCM and NM4R have funded in a pilot grant award to look at combining the neuromodulation approach with regenerative rehabilitation. And that's Coyle Garg from St. Louis University, obviously in St. Louis, Missouri. So Coyle, can we, Michelle, can you have her be able to share the screen?
She should be able to share.
Okay.
John may need to stop. Oh, there we go.
Oh, there we go. Okay.
Okay, so hopefully everyone can hear me okay, can see my screen. Everything good? Great. Okay, so I will sort of talk about some of the preliminary data that went into the grant proposal that was funded through this mechanism. It'll be sort of a shift from some of the talks that we've been hearing today, because I work pretty exclusively with animal models. So I'll dive right in. The focus of my research is on volumetric muscle loss. So for those of you who may not be familiar with these injuries, these are defined as traumatic or surgical loss of muscle tissue that results in functional impairment and could down the line lead to permanent disability. So when we think about skeletal muscle, we sometimes think of it as a tissue with very high regenerative capacity. Well, volumetric muscle loss sort of overwhelms that capacity for regeneration. And it's characterized by persistent inflammation, fibrotic tissue deposition, and really little to no muscle regeneration. And all of these factors together make it an irrecoverable injury. And it's pretty prevalent in modern military conflicts, but also can occur from high impact motor vehicle collisions or from gunshot wounds. And clinical treatment options are really limited. Physical rehabilitation is, of course, the standard of care for these injuries. But there is no regenerative therapy that can sort of restore that mass of muscle that was lost. All of the treatment options that are available clinically focus mainly on strengthening whatever is left. And that's where physical rehabilitation comes in as a pretty big part. But physical rehabilitation is also not without challenges. So a majority of these VML injuries occur in orthopedic trauma cases where there is a bone fracture. So there are cases where there is so much pain and there's so much weakness in those tissues that the patients are unable to engage optimally in a physical rehabilitation program, or often the physical therapy program, the initiation of it is delayed, which definitely has consequences to the healing of these injuries. So the rehabilitation strategy that we are proposing involves involuntary muscle contraction using electrical impulses. The method that we are using is very complementary to resistance exercise training. And it's been known to promote neural and muscular adaptations. So eccentric contraction training is what we are proposing. And it has been shown to improve muscle strength in both rodents and humans. And it's one of its major mechanisms is that unaccustomed loading that's placed on the muscle that's ultimately responsible for improving muscle strength. So I'll dive right into our experimental design. So here is the therapy that we are proposing. So we have rodents. These are male Lewis rats. We make a volumetric muscle loss injury in their tibialis anterior muscle. Then we let them recover for 2 weeks from that initial injury. And then at the end of those 2 weeks, we begin our electrical stimulation protocol. This is eccentric contraction training via electrical stimulation. And we perform this training at 3 frequencies, 50 hertz, 100 hertz, and 150 hertz, keeping all of the other parameters constant, like your voltage, current, pulse width, duration, all other parameters are kept constant. The only thing we are changing is the frequency. We also have a sham group that receives the VML injury but does not receive any electrical stimulation. And I'm often asked about this, so I'm just going to put it out there in the beginning. We sort of came up with this 2-week delay period because we thought that A, we need to let the muscle recover from that initial trauma to some extent. And B, we wanted some of that wound healing process to commence before we started the electrical stimulation protocol. And one of our major motivators was the idea that we wanted to, down the line, implement this protocol in combination with a regenerative therapy. And we wanted that regenerative therapy to essentially have enough time to do its job, to support enough myofiber growth in that defect area. So in order to achieve all of those things, we decided to delay the application of electrical stimulation by at least 2 weeks. And in this study that we designed, we wanted to look at the acute effects of electrical stimulation. So we just did 1 week of this therapy, and we sacrificed animals at the end of that 1 week period. And then another set of animals underwent this therapy for 4 weeks total. So we sacrificed them at 6 weeks after the VML injury. Okay, so here is kind of how we implemented the protocol. So you can kind of see the eccentric force curve from the screenshot of the program that we are using. And here is our electrical stimulation protocol. So hopefully this video will work and you can see what we are doing. So we essentially clamp the knee, tape the foot to the foot pedal, and then the foot pedal moves, so we are able to stretch the muscles. And as they are being stretched from dorsiflexion to plantar flexion, we are stimulating the peroneal nerve via those electrodes that you see at the top that are stimulating this muscle. These electrodes that you see at the top that are stimulating the TA muscle. So what we do is each bout of training involves 4 sets of 5 eccentric contractions, and we do it twice weekly. Okay, so I'll stop this video here. And here are some of the results that we see. So here is, so this protocol is implemented twice a week, right? So this data that I'm showing you on the eccentric force curve that says after second bout, that's after that second day of training. So it's after the second bout of training. So you can see that the eccentric force is not so high after the second bout, but by the time we get to the 8th bout, which is at the end of those 4 weeks of training, we do see this increase in eccentric force. So we are plotting it multiple different ways here. So here is the eccentric force at bout 1 to 8. So you can see that the 50 hertz stimulation doesn't really show that increase in eccentric force. It stays pretty much the same throughout. But if you look at the 100 hertz and the 150 hertz of stimulation, we do see that repeated bout effect. So here I'm showing you the delta of the eccentric torque. So the eccentric torque that we measure at the end versus the one that we measured at the beginning. And we see a significant increase in that eccentric torque at 100 and 150 hertz frequency compared to the 50 hertz of stimulation. So all in all, this tells us that we have 2 potential candidates, the 100 hertz group and the 150 hertz group, that might improve muscle mass and function. So that's the next thing we looked at. So here is muscle structure and mass after 4 weeks of training. So we do see an increase in muscle mass with those 2 high frequencies of training at 100 and 150 hertz compared to our sham group that received no training. We also looked at force production by these muscles at the end of 4 weeks of training. So this is now peak isometric torque that we are measuring. And that was improved significantly compared to sham only in the 150 hertz group. So basically we see improvement in muscle mass. That is about 37% for 100 hertz, 42% for 150. And in terms of force, we see a 37% increase with the 150 hertz stimulation compared to the sham group. So all in all, pretty exciting. We do see a repeated bout effect. We do see improvement in muscle mass and also in muscle force. So the next thing that we looked at was potential mechanisms as to how this therapy is working. So we looked at myofiber number and cross-sectional area. So we did see an increase in total number of myofibers when electrical stimulation was implemented at 150 hertz. In terms of mean fiber cross-sectional area, it was improved in, once again, in those two training protocols with those high frequencies. We also looked at fiber size distribution, and I would direct your attention to these large fibers. And here we are looking at percentage of total fibers. So you can see once again, those two high frequencies, they show an improvement in the proportion of those large diameter fibers. So this would suggest that our electrical stimulation protocol is supporting muscle fiber hypertrophy, which was one of our goals. We also looked at gene expression profile for a variety of markers, and I'm showing you some of that data here. So we looked at the inflammatory response. CCR7 is a marker for pro-inflammatory macrophage-based response. Nothing really to show here because our treatment groups weren't really significantly different compared to the sham. But if we look at the anti-inflammatory macrophage marker, which is CD163, now we start to see, once again, that the training implemented at those high frequencies had elevated gene expression of that anti-inflammatory M2-like macrophage marker compared to the 50 hertz group. And also compared to the sham group. So this is pretty exciting because in the literature, it's shown that modulation of that inflammatory response is one of the main driving factors behind that repeated bout effect that's often seen with eccentric contraction training. So we dived a little bit further and we decided to look into myogenesis and the neurogenic response. And in terms of myogenesis, we did see elevated MyoD expression, and day 21, once again, is after that 1 week of electrical stimulation. So it's like an acute response after that animal has had 2 sessions of electrical stimulation training. And then at day 42, it wasn't significantly different from the sham, but the 150 hertz was different from the 50 hertz group. So we did see increased MyoD expression when implementing the protocol at high frequency. In terms of neurogenesis, any kind of electrical stimulation, whether it was performed at 50, 100, or 150 hertz, improved the expression of nerve growth factor in these muscles compared to the sham group. So that was interesting to see. And we also looked at the angiogenic response, which was also higher with implementation at high frequencies. So all in all, from this, we are pretty happy with our results that we have so far. We are able to show that our eccentric contraction training protocol can improve muscle mass and function, and also myofiber cross-sectional area. And we are currently diving a little bit deeper into some of the mechanisms, but so far we've been able to show that gene expression of markers associated with myogenesis, neurogenesis, angiogenesis, and anti-inflammatory macrophage responses are going up with this protocol. Just a side note to what I am presenting here, we also believe that this rehabilitation protocol might be a bit more clinically relevant because of that delay in the implementation of that protocol, because we believe that most of the orthopedic trauma patients who begin VML or who begin physical therapy after volumetric muscle loss injury do so after significant fibrosis has already occurred in the VML defect. So if we are able to reverse some of those changes, even with delayed application of this protocol, then we do think that there are certain advantages. And now I'm going to talk a little bit about what our plan is moving forward. So our plan, of course, is to implement this rehabilitation protocol in combination with a regenerative therapy. And I won't go into all the background, but I just wanted to say this one little piece of information, that rehabilitation strategies on their own are thought to be supportive of muscle hypertrophy, but they're not capable of supporting hyperplasia. They're not capable of supporting new muscle fiber growth. So the goal of a synergistically applied regenerative rehabilitation technique is to improve the extent of hyperplasia or myofiber growth through the regenerative therapy. And then if you implement the rehabilitation protocol after that regenerative therapy has promoted myofiber growth, then you can maybe help support the hypertrophy of those newly regenerated fibers. And that's what we are hoping to see with the project that we currently have going on. And for that, the regenerative therapy that we are proposing is this biomimetic sponge therapy that we have been working on now for a number of years. And the therapy is entirely based on ECM proteins. So we take gelatin, collagen, and laminin 111, pretty standard ECM matrix proteins. We cross-link them together with a chemical cross-linker that's non-cytotoxic, that doesn't get incorporated into the structure of the matrix that we make. And while we did add the immunosuppressant in a couple of studies, we won't be adding it in the one that we are currently proposing in combination with the electrical stimulation protocol. But because in my past research, we included it, I'm just going to show you how that would work. So we take this immunosuppressant. This is FDA approved. Is pretty commonly used on organ transplant patients. So we take all of these components, we mix them together, we allow them to form a hydrogel, we then freeze and lyophilize that hydrogel, and we end up with this really spongy structure. And here is how the different matrix proteins are kind of interacting with one another. This design process allows us the freedom to incorporate any kind of growth factors or any kind of drugs into the matrix if that is desirable for a particular application. Using this biomimetic sponge therapy, we have so far tested it in a mouse model of VML, in a rat model of VML, and also in a rat model of composite trauma where we injured the muscle, but also made a fracture in the adjacent bone to kind of mimic some of the orthopedic trauma situations that these VML injuries are commonly found in. And in all three of those studies, we saw increased myofiber growth, as you can kind of see from these pictures here. So the red here is staining for collagen. So it's indicative of fibrotic tissue deposition. And the green here is just myosin heavy chain. So that's staining for the myofibers. With the implantation of this therapy, we almost always see this increase in the total number of myofibers. So it is capable of supporting new myofiber growth. We also see an increase in myofibers with centrally located nuclei, suggestive of regenerating myofibers. this implementation of this regenerative therapy led to about a 33% improvement in peak isometric torque in a VML model, but it actually performed a lot better in that composite trauma model where we had the adjacent fracture, where it improved peak isometric torque by 57%. So it is capable of improving muscle fiber growth and improving muscle function. So with that, our hypothesis for the project that we are currently working on is that we do see an increase in myofibers with our biomimetic sponge therapy, and we do see an increase in muscle mass and hypertrophy with our electrical stimulation therapy. So we believe that the combination of the two should definitely improve outcomes for VML injured rodents. And with that, I just want to put this disclosure out there that my students who have been working on this technology for some time have decided to launch a startup that's developing products related to the biomimetic sponge therapy that I talked about. I have equity interest in that company, and I serve on the company's scientific advisory board. And the terms of this arrangement have been reviewed and approved by the university. And I would just like to acknowledge some of the funding sources that have supported the work that we have done so far. We were fortunate enough to get funds from DoD and NIH that supported all of the data that I showed you here today. And I'll be happy to take any questions.
Okay, we're running a lot late. That's okay. Two questions, and then we're going to go on to our next speakers who have short talks. One question was with stimulation, was the change only in the targeted muscle or in the group as a whole?
Change in the target muscle or the muscle group as well. So with change, because all of the CSA and the muscle mass, all of those changes were in the tibialis anterior muscle only, because that's the muscle that we analyzed. But if you're talking about peak isometric torque, well, that is taking into account the force that we are measuring from the anterior compartment. So that includes all the muscles that are in the anterior compartment, but their relative contribution is pretty low compared to the TA muscle, because TA muscle is like the biggest muscle. So majority of the force is coming from the TA.
And the last question is actually from our next speaker. Julie asked, have you considered the addition of proteomic stem cell matrix with greater volumetric loss, as in Pitts, the stuff from Fabricio Ambrosia and colleagues?
No, I have not, but I'll be happy to look into it.
Okay, so why don't we move on to Julie? Does Julie have capability of controlling
She
screen?
should.
Hi, so I have been having computer trouble, and I just got my computer to start working halfway through Jonathan's talk, so I don't have my slide to put
I
up.
can share it. I think I have it.
Okay. Thank you so much.
Yeah, give me 1 second here.
I think maybe we should introduce the purpose of the next two talks.
Yeah. Why don't you go ahead, George? You can take that one away.
Okay. So we're, I think people know that they were invited to make pitches. You know, that one of the advantages of conferences is that we actually can have exchange of ideas, and so the idea here is with the group that we have assembled today to give sort of rapid feedback to ideas that would combine neuromodulation with restorative therapies.
And Julie, why don't you introduce yourself? I don't know what university you're from. I don't have that in front of me.
Okay, yes, absolutely. Hi, everybody. I'm Julie Schwartfeger. I'm at the Rosalind Franklin University of Medicine and Science, and I'm actually also in my research postdoc with Dr. Teresa Pape's lab. I'm her newest postdoc fellow. So I'm very interested in pursuing doing more research in neuromodulation with brain injury and neurologic populations. And I also have been developing collaborations with animal model researchers and have a great interest in including biomarkers and regenerative medicine experts in collaborations in the future. So with that, I hope I've made clear, I'm a bit of a neophyte in this area, but fascinated by the literature and delighted to be here and bring this forward to see if there's interest or good advice on this conceptual sharing that I've got for you here. Okay, so with that, low dose TDCS or transcranial direct current stimulation and intranasal platelet-rich plasma, proteomic cells, combined with a therapy intervention of Love Your Brain Yoga, which is a yoga that's breathing-based and focused on people with brain injury. So it's very accessible and has some evidence base behind it. So the idea was that combining these treatment techniques would improve resilience and physical health in people with chronic TBI who also have seizures, so would not be eligible for many of the research treatments that are out there currently due to the seizure issue. So I just, with that, went through some of the things that each of the individual components of the combined treatment would look like. The first would be the low dose, low dose TDCS to the intersection of the Con and Dan neural nodes to improve awareness and enhance learning when paired with therapies and provided at the same level of treatment effect with lower stimulation than regular TDCS, which would be important for people with seizure disorders. The second would be the intranasal platelet-rich plasma, which contains growth factors and cytokines to enhance angiogenesis, collagen, and protein synthesis that aids in cell proliferation neurogenesis to mediate inflammation pathways via COX-1 and COX-2. The third is the stem cells delivered intranasally also. These bypass the blood-brain barrier to enter the CSF within 10 to 15 minutes. This then increases ATP, energy production, and hippocampal neuronal growth, as well as anti-inflammatory microglia, and it reduces cortisol and beta amyloid and tau deposition. And then the last would be the physical intervention, which is the Love Your Brain Yoga. This is a 6-week evidence-based intervention accessible to people with brain injuries and their caregivers. It's breathing focused, and it's evidence to improve body awareness, resilience, and mood, while also reducing cortisol and adverse health. So this is just a concept. It's a lot for me as a new research fellow, and it's combining things that definitely go beyond my reach. It would be things to be developed in collaboration with experts in the regenerative and biomarker space.
So any questions for Julie or comments?
Yeah, so I have a comment maybe to get things kicked off is that, this is a list of a lot of different things, a lot of different mechanisms. And, it doesn't really sort of fit into a kind of reductionist kind of research program where you really figure out where there's, where the interaction is happening or the mechanism. And particularly, I was involved sort of peripherally in a study looking at functional brain imaging, yoga, and appetite. And I'm a yoga practitioner, so I'm very favorably inclined to yoga. But as an intervention, it's just a combination of so many different things that it's really, if you're then using this design a program, it'd be very hard to know which of those elements was actually responsible for an effect.
Yes, that's an excellent point. And so I think what I would say to that is to put a label on what you've just described. One, it gives away my background as a practitioner, right? And then second is it definitely fits in with more along the scale of pragmatic side of the research. And it would count very heavily on the good work of the bench scientists and the more mechanistic science going on for the individual treatment, since there's a combination, and since the specificity of the yoga, since it is something that you can't say you're doing one very specific thing in a very isolated, controlled environment. With that loss, the translational side of it is very compelling, and I think can harness some of the bench research for each of the individual techniques that get at the mechanism. But yes, it would fall under the more pragmatic side of the spectrum for sure. Thank you for that good point.
Any other questions or comments? Julie, thanks for putting up your slide and comment and responding to George.
Thank you.
The next person who has a slide to talk about some new ideas is Juan Yang. Do you have access to your slide?
Yes. So I need to share my slide, or?
Yeah, if you could. Otherwise, I think we have a copy.
Oh.
If you can just go ahead and share, that'd be the quickest.
Okay. Yes. Okay. Let me quickly share that. All right. Pull here. All right. So,
if you have trouble, I can. Okay.
Yes, I have it here now. Okay. So I'm Yuan Yang. I'm from University of Oklahoma, and I'm a faculty in biomedical engineering. Since I have an engineering background, so here that's basically what I do is to develop a targeted high definition TDCS. So this high definition TDCS has been in market for decades. What I do here new is basically I combine that with diffusion tensor imaging. So therefore, I work with a stroke patient, and I can see that how focused these things, not only for the cortical region, but also underlying the cortical region, how that influence neural fiber. So here is basically I provide this kind of a computational modeling things. So MRI, DTI, these kind of that's from the real data, and this red part is the electrical field is the computer simulation. So that's we can do that and do that more targeted, and then we can go back do that on our patient based on our computer simulation. And we have did that in few moderate to severe stroke patient. When I was in Northwestern, I did in Northwestern. Now I go to Oklahoma. We also did few in Oklahoma, and we all see they get some improvements. So like they do in the box and box for the mild patient get improved it. Full mild score get improved it for the moderate to severe patient. All patients get the TMS evoked potential latency reduced for the cortical spinal tract. And we also do that with EEG simultaneously. We can do simultaneous stimulation and the recording, have a way that to suppress the noisy. And for that, I submitted an NSF career right now. It's under review. We are about to receiving a pilot grant to do a pilot trial using this technique. So I'm working on the just in time. Thank you.
Thank you. Any questions or comments? So this, I guess I was going to ask questions for some people that are in the regenerative medicine world, but I'm looking at Dr. Yang's approach, and again, I am not a regenerative medicine type person, but you would imagine that if you could get computer guided, very focused stimulation or brain stimulation or things that are very focused, that if stem cells are implanted, any type of regenerative rehab approaches, do people in that realm who are here see how focused stimulation might be able to help shape what's going on in some of these circuits that are being developed?
Yeah, so that is actually my goal here. And also, although I'm an engineer, I do like a hypothesis-driven the way to do the things. And one hypothesis, if we stimulate the lesion near the cortical spinal tract, the person's weakness problem may get solved. Through that may reduce the fraction synergy and the spasticity problem. On the other hand, I also trying to target the premotor region and underlying cortical radicular spinal pathway, and from that may help reduce the fraction synergy or spasticity, and from that might also improve the hand function. So that's kind of my hypothesis I'm working on that. Appreciate.
Yeah, I think following, on that, the question is whether you need to combine this with some sort of behavioral program, because, if you imagine multiple behaviors being represented in the areas that are being stimulated, if you're injecting currents, it goes indiscriminately in all those overlapping kind of representations. But if you're trying to strengthen something, I think following on Jonathan's nice talk, that you have to do something to create specificity. Even with a sort of high definition array, it's still not high definition when it comes to the level of behavioral specific circuits.
Yeah, that's true. And right now we are more like doing some simple tasks, like lifting these type of things help us to identify the region. And I'm fully agree with you. Yeah, that's if you have a more complicated task, it may involve more region, and maybe not only like these 5 electrodes, maybe requires the whole cap stimulation to target a different region. Yeah.
Right, but just to emphasize my point, it's not just about the regional specificity, it's about the circuit level specificity, which you can't access, within any sort of, even an implanted electrode is not likely to be specific to particular circuit, because there's such a dense packing of circuits in the brain.
Right.
Any other comments? Linda?
Yeah, just for my own edification, because this is, of course, fairly new to me. Can you explain to me the cerebellum that I see there? It looks like you're reaching the cerebellum. Am I misinterpreting that?
No, this is just the fiber imaging. The blue is the fiber. The red is the electrical current. It's so the electrical current will not be able to go that deeper if I put it here. Yeah.
Okay.
So that's something from DTI.
That's from the DTI. That's just the fiber projection. I should make it more clean. That so that's basically in the cortical spinal tract go down.
But
yeah.
But what's the interpretation of the cerebellum in that context?
No, this part that the fiber, I should not visualize that. It's just
okay.
Yeah, no.
Okay.
So this one is the cortical spinal tract. That's from the M1 go down. Yeah.
Would it be fair to say that's fiber tracking error that's being represented there?
Yeah, that's just the diffusion tensor imaging. That
error.
Yeah.
Okay, got it. Yeah.
Oh, yeah.
Thank you.
So Linda, I guess I have a question for you. And you're thinking about John Wolpaw's talk about these hexers, which really are, I still have to digest, I guess, a bit. But I guess one of the questions is, we can have all these techniques like neuromodulation or the regenerative medicine techniques, but we're trying to activate these together in some way to perform, to have behavior be improved. It sounded like from one of John's points was that even with what he called a broken Hexer, which I guess could be a new transplant or something too. I mean, how do you think some of these tissues might respond to some of this stimulation? I mean, I guess it's a loaded question. This targeted stimulation with the behavioral training going on with it so that it's meaningful.
Yeah, I don't know. I think it's sort of a new frontier, isn't it?
Yeah.
So I don't know. I don't know how to predict that. I know what I hope would happen, but yeah, I don't know. I mean, you only will know unless you have to try it out, right?
Yeah.
So, because there's also this, I mean, there's this dosing thing too, the dosing and timing that we think about pharmacologic intervention, but it applies to all, all these avenues of trying to improve outcome. How do you, aside from the site, how do you balance that out? And it's, to some degree, it's kind of, you go in with an idea of how you define the dosing and look what happens in that context, alone and in combination.
So
I mean, how else would you do that?
Yeah. So it sounds like we need to have some, discussions or, about what are the best ways to start trying to address those problems and prioritize even some small studies that might start to give us a handle on some of this.
Yeah, I mean, and at the level of the microenvironment too, what does it do in that context? I mean, I think about, like, for example, stem cell transplantation in the injured spinal cord, and then something on top of that, some kind of stimulation that would further support that environment that would facilitate the functionality of these stem cells. What would that be? I mean, you're looking at the microenvironment to support the plasticity of these stem cells, which already show some plasticity, but you want to boost it.
Yeah.
I mean, to me, that's like the perfect avenue to bridge the two areas.
I used to have a mentee, Anne Marion Taylor, who was, I don't know if you know her, but she was out at, she was a Carl Kottman postdoc.
Yeah.
And then was out at NC State, and she did microfluidics.
Yeah.
And she could have like 1,000 pyramidal cells, cortical pyramidal cells in their little, in their little tracks, where she could do different types of interventions, mostly pharmacological, but she could create lesions and so forth. I'm just wondering if some of this starts out in a dish, and see how we can, if microfluidics, I'm not an expert in that at all, but that's one of those ways we can do high output or high throughput studies.
Yeah.
Any other comments from people as the witching hour is approaching? Well, I hope people enjoy this and hopefully stimulate some thoughts. And thanks to everybody who are speakers, and in particular, thanks to Coyle, who's actually trying to tackle some of these issues in a really a huge clinical problem with this muscle loss. It's a little different than what most of us deal with. George, Linda, you want to say anything as we depart?
No, I'm just excited about the possibilities. And I do see this, I mean, a lot of extreme interest in this. It's like a new frontier where there's so many possibilities. I just think it's very exciting.
Yeah, I would echo that. And I think as you go into thinking about work, think about mechanisms. Doesn't mean not to try new things, but I think it's even though we'd like to think that that our theories will play out, be open to to new combinations and proving those combinations in these sorts of trials.
Okay. Well, everybody have a great weekend. we're going to have a very cold, rainy weekend here. Take care.
Thank you, Rick.
Right, bye all.
That was
Thank you.
terrific.
Bye.